Okay, let's talk a little bit about Chapter 5 here with Extra Cat. So here's some learning objectives for us. Let me move this around here. Alright, we're going to be discussing the use of localizer scans, and we've talked about those a little bit already in class, but we'll talk about how they work to determine our display field of view, as well as image center, all of those things we can kind of build around a localizer scan. We can't actually move where ISO center is, but we can change where the image center is. And then we're going to engage in an active put-down contest with axial scanning, and particularly detailing the degree of its obsoleteness and general stupidity. So if anyone has your mama jokes, this would be a good time to use them, and it's based around axial scanning. Okay, that's where the CAT comes from, right? Computed axial tomography, which really there's no reason for us to be doing any axial work anymore, and we'll talk about why that is. That's why I've made such a strong point on that. We're going to illustrate instrumentation and techniques related to helical scanning with MDCT. That means multi-detector CT scanners. Basically every CT scanner you will ever work on, you could call MDCT, so it's kind of obsolete, but that's the terminology she uses in the book. We can just call it a CT scanner. And then given certain scan parameters, we're going to learn how to calculate pitch. So pitch is a big takeaway in this chapter. It's one of the major things that I want to make sure that we understand. And the reason I have us calculating is because I feel like if we can do some of the math around, it's pretty basic algebra, but if we can do some of that math, it'll give us a better understanding of what exactly pitch is and how it influences the images. And then we'll discuss relationships between interpolation, table speed, slice thickness, pitch, and scan coverage, because that's kind of a big part of what we do as CT techs as we're determining the area that we're going to scan. We're making a lot of determinations about the quality of the images that are going to come out of that scan. So where X-ray technologists learn about positioning and procedures all day, and maybe radiation therapists, we learn about different kinds of setups and how those could be used for different kinds of cancer treatments. CT tech, what we really spend a lot of time thinking about is scan coverage, slice thickness, pitch, table speed, as well as contrast injection. So this point right here, down here at the bottom, is pretty much every CT scan ever. If you can read this chapter and come away with a good understanding of that, you are well on your way to becoming a very good CT tech. So this is a significant chapter for us. So let's talk about these localizer scans. This is page 41 in our textbook. An optimal localizer scan is going to show the area to be scanned, right? So if you look at the top of page 41, we have a localizer scan that would be good for like a chest, abdomen, and pelvis examination, right? It would not be a good localizer scan for a neck. It would not be a good localizer scan for a head, right? So we need to be able to localize where we're at in that anatomy in three dimensions. So a lot of times for most CT scans, we're going to ensure that the patient's centered in the gantry in both the X and Y directions, and then we're going to plot from a 0 point along the Z-axis. So what the heck am I talking about? Well, for this one in our textbook on page 41 at the top, in all likelihood, where they placed their 0 was at the jugular notch, at the top of the manubrium of the sternum, right? That's where we typically 0 for chest, abdomen, and pelvis, for any chest work. Because it's a very solid landmark, right? And at this level, I can also make a determination. I can look at the side of the patient's body and make sure that they're appropriately centered in the y-axis, right? So I can make sure they're centered in the z-axis because it's right in the middle of my body, right? And I can also make sure that in terms of up and down, they are appropriately centered by looking at the laser along the side of their body, okay? Because I'm going to have a laser right here, crosshair right here, when I'm zeroing them at this jugular notch, and then I'll also have a laser along the side. So now I've made sure that the patient is centered both in the z-axis and in the y-axis, and now I'm going to tell the machine, this is your center for z also. So I may have said that wrong. I'll re-say that. I'm going to make sure that I'm centered appropriately for the x-axis and the y-axis, looking at this, and then I'm going to push a button on the machine that says, that's your 0 for the z-axis as well. And once the machine knows that, it can go to work, right? And it will give me this localizer scan that you see right here in front of you, right? And like we've already talked about, if we miscenter, this is an important part of our job as a CT tech, knowing some of this bony anatomy, making sure that we're centered appropriately in the gantry. It's one of the first things that often goes with seasoned CT techs, but people who really know the field know that that's important. Because miscentering can result in out-of-field artifacts, it can result in increased patient dose, and it can reduce image quality. So that's kind of the big three, like bad things that you don't want to happen with your X-ray, with your CT images, is crappy pictures, increased patient dose, as well as artifacts. Like, if I can just simply zero this thing appropriately and get rid of all of that, I want to do that. So you have complete power over this. And in the machine, like on a GE scanner, there's this little guy named Tom. He looks kind of like a Lego man or something, right? And you can flip him around. You can tell the machine, okay, Tom is laying on his back with his head towards the gantry. Or Tom is laying on his back with his head away from the gantry. Or Tom might be laying on his side or on his stomach. You can flip this little guy around. And that's what it's talking about with this information here about how you can tell the machine, is this person head first, feet first, prone, supine. It's very easily illustrated with a cartoon graphic on almost every scanner because they don't want you to screw that up. So they're going to make it as simple as possible to look at this little dude, flip him around, and make sure that it's right. Because incorrectly inputting that information, that person's direction, can result in mislabeled images. And you didn't just mislabel one image in CT, you mislabeled 1,000 images, right? So that one simple rotation of the little cartoon man could wind up mislabeling a lot. And the more stuff you've mislabeled, the more substantial a lawsuit would be against your butt, right? That's why she makes such a strong point about that. So we're talking about medical errors and minimizing them just by rotating a little cartoon guy around. And she talks about some of the ways that we can avoid miscentering and stuff on page 40. Those are pretty helpful. Yeah, and I think that's all I need to say about localizers. So when we think about them as they relate to display field of view, okay, so here's a localizer that was probably taken in the AP direction. And so like she illustrates in the textbook, the tube is directly above the patient, the detector array is beneath the patient, and what's happened to acquire this image is the machine has just moved the patient through the gantry, right? So it's moved the table through the gantry without moving the tube. So I got something that looks like it almost looks like an X-ray, right? It looks a lot like an X-ray of the person's chest, abdomen, pelvis. And I can even use it to a limited diagnostic sense. Like doctors will use this to facilitate diagnosis, this localizer image. So there's a lot embedded in it. But the way that we are going to use it primarily as technologists is we will now input the area that we want to scan off of this localizer image. So regardless of where the ISO center might be, most scanners, the way they work is they allow you to draw a box. And the box situation works like this. It's just like making a box on any other kind of image. You'll be able to draw, let me see if this will let me do it, draw it on there like this. And I didn't quite like that because it will not be a solid box, right? But that's the way that it will be drawn on there. It'll draw it on there like this, much better than I can draw it. But it's very precise. It's very precise, the box, right? And anything inside this box is going to be in the display field of view when I look at my CT images. Anything outside of this box will not show up on my display field of view. It might have been in the scan field of view, so that information might be there in the scanner, but when the scanner generates the images, I will not be able to see that information. Okay? The other thing that's happened with this is I've determined now an image center, right? And so there's some imaginary line through here that's the center of the image, right? And you can see it's slightly to one side of midline for the patient, right? So I can make an image center that's a little bit different from isocenter, right? I can set up these images to be centered however I want. So I have there's some latitude there, there's some freedom there to draw this box on there however I want. It's important, one of the reasons we get both an AP and a lateral image is if you can imagine, if I draw this box on there too tight, right, I might have clipped something in that lateral view. So the text will toggle between like this AP scout image and a lateral scout image, make sure that they've got everything that they need in both directions. Another good example of where you might want that lateral image is if you're doing a chest and you want to make sure you include all of the lungs. Every now and then there's people that have these lung gutters that go clear down to their pelvis, right? They've got these costophrenic angles that come way down to their pelvis. So I can only see that on a lateral view. What I'm talking about is if you look on page 41 on this lateral view, he's got a very flat hemidiaphragm. He does not have these costophrenic angles, but if you can imagine that rear part of the lung where it dips down, if it dipped really low, I don't want to clip that. If I'm doing a chest CT, I want to make sure to include all of that. Another way to think about this, if you look on the clinical applications, page 43, this box 51, make sure you read over that. That's coming straight out of the clinic. That's coming straight out of the hospital, that consideration. And it's one of those things that it just helps you think through a situation where you apply this stuff. It's a very helpful little box to be able to think through. I like seeing those real-world explanations. So here's a review question. Let me move this around. What is the risk associated with incorrectly inputting patient position, supine versus prone, for a localizer scan? I think my favorite answer is because cats. But the cross-sectional images would be incorrectly marked. They would be incorrectly marked. So we might still have an optimal display field of view, right? We might still be able to set the z-axis, the area that we want to scan. We'd still be able to draw that box on there. But the machine's going to think the head is where the feet's supposed to be, right? Or something like that. And there are instances in which surgery has been performed, right, on the wrong side because of a CT tech not flipping the little cartoon man around. Now, one little caveat there is this is not always as easy and obvious as it sounds. So we'll talk about that more this summer, but those folks in the MSK group, y'all sometimes are a CT tech's worst enemy. Like if I'm trying to do a CT scan of a wrist, how do I tell the little cartoon man the wrist is situated, right? The cartoon man gets really confused if you're just trying to scan like a wrist or an ankle or something like that. Okay, here's the part that's really stupid. And she spends quite a bit of time on it, talking about step and shoot scanning, okay? They are going to result in images that they're perpendicular to the z-axis and parallel to every other slice. And the metaphor she gives is like slices of a sausage. And so I've got these cats with flying hot dogs, right? Because they're stupid. And I'm going to talk about why they're stupid. One of the main reasons that they're stupid is they cannot be used for fusion. So these images are completely useless for PET-CT fusion. These images are completely useless for radiation therapy planning. These images are completely useless for 3D reconstruction. And the benefits that she outlines that they give us in terms of increased spatial resolution and things like that have largely been made obsolete by increasing progress in software development. So why am I harping on this so much? Why did I put all these cats in here? Is it just because I'm sick of being called a CAT scan technologist? No. It is because we are still doing this. If you go to just about any facility, like for example Baptist Memphis, right, not to call anyone out, they are still doing axial scanning of the head. Why? If you ask any of them, do you call yourself a CAT scan tech? They'll say no, right? Why are you doing axial scanning then? That's what we've always done. That's the best answer they could give you, is that's what we've always done, right? Now I'm going to have to edit that part out of the video. But the important point here is that this axial scanning does not have the benefits that it used to have in the past, and yet we continue to do it simply because that's what we've always done, right? There's a lot of things like that in X-ray, in our fields, in allied health in general, I would say, and I think every single one of them is worth questioning. So whenever you find something like that, it's appropriate to ridicule people a little bit. There is one exception though, right? There's always an exception to the rule, and there is a time when axial scanning could be useful, and I would say that's during any kind of, what would you call it, interventional procedure. So if we're doing an interventional procedure where, for example, we need to place a needle inside of an abscess and drain the abscess, it could be helpful to do single axial images, or a series of axial images, but a single axial image at the level where we're trying to place that needle, because we'll be able to help guide the needle in, right? So this is one instance that I can think of where axial imaging would be useful, is if you're working in the interventional suite assisting doctors in localizing needle placement. If you're not doing that, there's probably no reason other than that's what we've always done for doing them. Okay, so why is it stupid? Number one, the cumulative effect of all of this scan, move, scan, move, scan, move, adds to the total examination time. Where I could just scan and move, right? Like if I was, can you imagine if I walked like that? If I was like, walk, talk, that's what you're telling the machine to do. When it can walk and talk at the same time. The other thing is that if the patient breathes from one acquisition to the next, we cannot see that breathing movement. If their heart beats, right? Which it is beating, hopefully, if they're on your scan table, right? Because there's no birth, deaths, or conceptions on your scan table. So if their heart is beating, it will misregister that beat, that heartbeat, from one scan to the next, from one slice to the next. And then that raw data that you get, that rich data set that you have, is sliced up like little hot dog slices, right? So if you make a hot dog out of it, it's going to look like a Lego hot dog. And as amazing and delicious as hot dogs are, no one wants to eat a Lego hot dog, right? I can't imagine eating it. So the 3D reconstructions of the heart, the 3D reconstructions that we do for radiation therapy planning, the fusion of CT with PET CT, you can't do that with this data set. You would have to rescan the patient. So let's pause for just a little bit on that discussion and talk some about MDCT, or what I just call CT. She calls it MDCT because when this textbook was written, there were still people scanning on single detector CT scanners. That is gone. There's no one doing that anymore. No one. The government didn't quite outlaw it, but said stop doing that. Anytime we're scanning with it, it's going to allow us to scan quicker, because we've got a bigger bank of detectors. And we can then determine the area that we're scanning by the detector collimator. And so we can collimate the beam to the area that we want and create different thicknesses of slices. Here's what that looks like. This is in our textbook on in some detail on page 48. But I just want to point out that what this is doing is it's opening up that collimator further and further, and I believe this would be along the both the x-axis and the z-axis. So it almost makes kind of a cone-shaped or kind of pyramid-shaped beam that is specific to the slice thickness that you want to scan. So here's one of the more difficult questions in this presentation, right? And we're going to work through this together. But if there's an examination that calls for continuous 4 millimeter slices to be taken from the level of the sternal notch to the lung base, 60 slices are planned, right? How much anatomy in the Z direction will be covered with cross-sectional slices? Okay? We'll go ahead and look at the answer we'll here. All right, good. How did they arrive at that? Let's work it out. So, we've got 4 millimeter slices, right? And we've got 60 slices that are planned, right? So if I've got these 4 millimeter slices, I can multiply times 50, or 4 times 60, I'm sorry, and I'm going to get 240 millimeters. Are you tracking with me? This is not super complicated. I'm not trying to scare anyone with the math or whatever, but I want you to see that it's fairly simple. What we're talking about is the slice thickness is translated along the z-axis direction over however many slices we planned, and this is asking us, is it possible to cover the area of the chest with that? Well, I would need to know how big their chest is, right? And so this is one of the reasons why we don't sit around and do the math. We think about it geometrically and we just draw the box, right? We draw the box on the localizer scan. When we draw the box on the localizer scan, if we were computers or something, really all we're doing is just saying this. I want you to travel along 240 millimeters, I'm sorry. You tracking with me? We are able to think very rapidly in this geometrical way, but there's a very similar process that talks about, we can talk about it algebraically as well. Okay, helical scanning. I couldn't find a picture of a cat stuck in a spring. You know, I've spent like 50 minutes looking for that picture. It does not exist. So I've got a cat in springtime. But the way that we can think about helical scanning is think about a spring, right? Think about, what was it, Slinky? Is it the Slinky that goes downstairs and all that stuff? That's what we're doing. That's what we're asking the machine to do within geometric space. We're asking it to scan and move at the same time. So it's going to create a spiral. So if the axial slice is like a hot dog, right? Who here likes hot dogs, be honest? Like one of us, two of us? Okay, now let's be honest. Who likes honey baked ham? Most of us probably like honey baked. Not some of us don't. The axial image is a honey baked ham. If you look closely at the honey baked ham, it's been spiral sliced, right? I don't know how the heck they do that, but somehow they've engineered a way to do that. That's what we're doing in CT. We're spiraling the slice now. So this is going to allow for the key aspects. The way that we're going to pull that off in terms of engineering is we need to have a way to continuously rotate the X-ray tube. So what advent in technology allows us to do that? Slip rings. Yep, so slip rings allow us to continuously rotate the X-ray tube. And then we're going to have constant X-ray output. So we've had to figure out ways to have higher anode heat levels and heat dissipation and all those kinds of things. And then we're going to have uninterrupted table movement. So it is really important that the table is moving continuously at a continuous rate. It doesn't need to accelerate, it doesn't need to decelerate, it needs to move just nice and easy through this thing because we're trying to do that slice. And so the helical scan is going to produce these slices in which the beginning point and the end point are not in the same z-axis plane. What's that saying? It's saying it's a spiral. That's all that's saying. So here's some of those things that we outlined. And I didn't quite, it looks like the slide didn't include quite all the advantages in here, But this is definitely going to enhance our ability to administer contrast and be able to have it all in the same phase so there's no washout. We can scan more quickly. And then, like I've mentioned, the data set that we have, we are going to be able to think about three-dimensionally. We will be able to do computer processes on it that are three-dimensional in nature. So the way that we do that is through this magic trick called interpolation. Let me find where that's at. Yeah, page 52. She talks very briefly about 360-degree and 180-degree interpolation. Okay? Now, there are advantages and disadvantages to both. One of the main things that I would have y'all take away from this discussion of interpolation is if you look in the second column, about midway down right here, it says interpolation methods quickly improved from those first introduced, and this effect is not nearly as pronounced on scanners used today. So the problems that we had with interpolating data are not as bad as they used to be. The big one that we're talking about is what she calls slice thickness blooming. Slice thickness blooming. Now this is something where you're going to have to put on your thinking hat a little bit, or your thinking cap or whatever. There's an illustration of it on the bottom of page 52. What has happened is there is an amount of data, right, that the machine is having to make up. And as the machine makes up that data, it's going to make the slices a little bit thicker than they actually were. So if you look, the axial slice was exactly 1 millimeter in this case, because it went from negative 5, it's exactly 10 millimeters, I should say, because it goes from negative 5 on one side to negative 5 on the other pretty evenly. So that's a 10 millimeter slice. Versus the helical slice is a little bit bigger than that. Like it's like 12 or 13 millimeters thick, right? This basically is a degradation in slice sensitivity. We no longer have slices that are as sensitive to the area that we're scanning as we want them to be. She says that at the top of the page on the second column. This is a slice blooming is a degradation of image quality. It degrades image quality. So we are going to use these different interpolation techniques to try to mathematically correct that, right? And so she says interpolation is associated with some loss of image resolution. That is true. And slice blooming is the way that that occurs. Let's talk about what that actually looks like. So we are rotating the scanner around and around as we're moving the table through, right? So we've got two different kinds of interpolation that we can do. We've got 180 degree, and I think I've alluded to this in the past, and then we've got 360, right? The way that the 180 degree works is it's going to take 180 degrees of tube travel and interpolate that data back, right? It's going to back project that amount of data, right? So if you look, that's less data, so the interpolation will be more accurate, right? Versus 360 degrees, the tube is going to travel 360 degrees, right? But it travels in a spiral, right? So now we've got to interpolate all of this. And as you can imagine, that's going to result in some decrease in image sensitivity, okay? That's really all you need to know about it. That's as in-depth as we need to get on that. Any questions about that? So don't let that big fancy word scare you. Okay. The steeper the angle of the slice, the more interpolation will be required. Okay? And when we talk about the steepness of that angle, what we're really talking about is pitch. Okay? Pitch. And it's also on page 52 and page 53. These are, in terms of understanding helical scanning and everything, these two pages are solid gold. Unfortunately, we don't really get a definition for pitch until the top of page 54, where she says beam pitch can be defined as table movement per rotation divided by beam width. Okay? She kind of bogs us down in some stuff here. So let's try to unpack it a little bit. So pitch is going to be the parameter that defines the CT table movement during the helical scan acquisition. Okay? And the most commonly traveled distance of the CT scan table per 360 degrees rotation of the tube will be divided by the X-ray beam collimation width. I know I just said a whole lot, but basically if the amount that the table moves is the same as the width of that slice, the pitch is 1. So it exactly matches the table movement with the width of the slice. It matches the table movement with the width of the slice in a pitch of 1. If the table is moving less than the thickness of the slice, then we will have a pitch of something less than 1. Right? It would be that much more sensitive because the slices are that much closer together. The table's not moving as much. If the table is moving faster than the width of the slice, then we will have a pitch greater than 1. And that's when we will start to lose some data, or we'll start to see blooming and things like that. That being said, on page 54, she says that the most common pitch is between 1 and 1.5. The most common pitch is between 1 and 1.5. It's in the key concept box. A couple of things that you can kind of gloss over here real quick is the discussion of single row detector systems on page 45. We don't need to think about single row detector systems. No one's doing that anymore. Another thing you can kind of gloss over here is, and all this builds towards pitch, is applications, where she talks about applications related to axial imaging. We've mentioned that to some degree. That one's on page 50. We still do that some, but it's not as important. And then page 54, just so we don't get confused about pitch, go ahead and scratch out where she talks about detector pitch. We do not need to think about detector pitch. That's not helpful. The area about pitch and scan coverage that I'm interested in is page 55, where it says MDCT scan coverage. On page 55, MDCT scan coverage, that basic math there. Okay, so here's what that might look like on an exam. Considering the following. You have a 16 slice CT scanner. Okay? You are doing 0.5 millimeter slice thicknesses. Okay? The table of movement is 12 millimeters per rotation. What is the pitch? So the first step, what's the first thing we need to do on this? 16 times, 0.5. So that should give us 8, right? If I can write here. 8. And I know that, so this is 8 millimeters, by the way. 8 millimeters. So is the table moving more than the slice width, the beam width? It says it's moving 12 millimeters. So is it moving more than this? I have 12 millimeters and I have 8 millimeters. My beam width, this is my width here. And this is my movement, is 12. So which is bigger, my movement or my width? My movement is bigger. So if my movement is bigger, I would expect my pitch to be greater than 1. Right? I always do this in the back of my mind because if you do these kinds of questions, you'll never screw up this stuff. Even if you don't know which is supposed to be on the bottom and which is supposed to be on the top, if I know that the pitch should be greater than 1, then I can figure out which is supposed to be on the bottom, which is supposed to be on the top. Do you get what I'm saying? So which is supposed to be on the top right now? The 12 should be on the top because that will give me something greater than 1. And I'm not sure what that is offhand. 1.5. Good. Let's see if we're right. Great. And here's that worked out again. But rather than bog you down with the math, like you don't really need to memorize this formula. What you need to be able to say is, okay, which is bigger? The thickness, like the width, or the movement? Is the width bigger or the movement? If the movement is bigger, I'm going to see a pitch that's bigger than 1. If the width is bigger, I'm going to see a pitch less than 1. If they're identical, I will see a pitch of 1, period. Right? If I know that, if I can think through that before I do the math, I can figure out the other stuff. But here, all we did, again, was we multiplied that 16 slices times the 0.5 millimeters, which gave us 8 millimeters, and then we said 12, which was the movement, divided by 8 equals 1.5. So our pitch is 1.5. The final kind of piece in this puzzle, and kind of one of the big takeaways for us today, is figuring out helical scan coverage. So now that I know that I've got this ability to move the table quicker than the slice thickness, I need to be able to figure out what's the area that I've covered with the CT scan. And again, we typically think about this geometrically, right, when we draw our little boxes on there, but it's also helpful to be able to think about this algebraically because it allows us to see every little technical detail of the scan. And all these little technical details here, the pitch, the acquisition time, rotation time, slice thickness, all of those have impacts on patient dose. They impact image quality. They impact noise, all of those kinds of things. So that's why I'm asking us to break this down algebraically. As a CT tech, will you be sitting here doing this formula every day of your life? Heck no. You'll be drawing boxes on people and telling the scan to scan them because you need to get them out in and out as quick as you can. But to know this is basically the heart of CT technique. This is how we improve images, how we decrease dose, etc. So what we will do to think about distance coverage, we need to think about the pitch. We need to think about the time that we're given to move the table. The time that we're given to move the table. As well as the rotation time of the machine itself. How quickly can it rotate? And then we're going to, together we're going to multiply the slice thickness and the slices per rotation. So whatever that slice thickness is times the machine, the 64 or the 16. And they don't just pull those numbers out of thin air. right? Every single number of CT slices, right, is a binary number. So what does that mean? It is a factor of 2. It's 2 to the something, right? So for example, a 8-slice machine is 8 slices because it's 2 to the 3rd power. 16-slice machine is a 16-slice because it's 2 to the 4th power. Do you get what I'm saying? So the slice thickness of a CT scanner is directly related back to binary codes of computers and stuff like that. So there's no such thing, for example, as a 17-slice CT scanner. But we will have you'll be given this information, a 20-second acquisition time, a 0.5-second rotation, 2.5 millimeter slice thickness, a 4-slice machine, and a pitch of 1.2. If I have that material, I can tell you how far of an area the scan will cover. Okay. What's interesting now that we have this data set, so let's take a step forward now and ask the next question. We've got our data set now. We've got our helical data set. We have the power now, since we acquired a chunk of data, and it's not just hot dog slices, like it's all this solid chunk of data. We can change slice incrementation after the fact. So say I don't need the 0.5 millimeter slices, I just need 1 millimeter slices. I can increase that, and it will actually wind up improving my image quality. So this allows us to create overlapping slices without increasing radiation dose to the patient. This is a really powerful tool. So if we understand pitch, if we understand this incrementation stuff, we're able to improve image quality and reduce dose. So there's always a balance in CT, and so the risk that we run is that we could cause some partial volume effect. What does that mean? Well, it's basically an artifact where something looks like it has a volume that it really doesn't have. She talks more about it in the textbook, and you can look at page 55. You can piece it together. It's pretty well illustrated. There are some situations that are fairly rare. So I mentioned that we could, if we had a incrementation that was small, right? If you think we've got these little tiny increments, right? I can reconstruct it into a bigger increment, right? That's a given. But if I have a big increment, right? It may be more difficult to do this. Like this is not necessarily a given. So in some situations, the thicker slices can be reconstructed into thinner, but not always. This other situation where the thinner slices can be reconstructed into thicker is always the case. All right, that's it.